Greetings. This is Prosthodontics on Friday Night Live, which addresses different steps of prosthodontic treatment and its side effects. Today we have a lecture on full denture. This is in light of the Back to the Basics series. First, we're going to talk about impression taking, which is a very foundation for full denture treatment. We're going to focus on the upper. Today we have with us Professor Kwon Gong-nok of Prosthodontic Division at Gyeonggi Dental School. Nice to meet you. Thank you for coming all the way here. I know you're very busy teaching, researching, and treating patients. I'm honored to be here. Professor Kwon, before you begin, could you briefly introduce today's lecture? Today I'm going to focus on impression taking in the upper for edentulous patients. In most cases, people perform this procedure very easily, but I want to emphasize some tips to enable successful clinical treatment, and I want to reiterate the basics. Perhaps you may have forgotten a couple of things because you've learned it so long time ago, or you may be performing certain procedures blindly without giving it much of a thought, and we may need to go over that once again. I looked forward to today's lecture even more. Those of you watching from dental site, you can participate real-time via the chat and leave your questions. These will be addressed and you may win Starbucks coffee coupons. Those of you who leave the most memorable questions will be selected as best questions and you'll be sent a Views and Music Tiger dental set. Learn about full denture and win amazing prizes. I look forward to your keen interest and participation, and let us begin today's Prosthodontics on Friday seminar. Greetings, I'm Professor Kwon Gong-nok of the Prosthodontic Division at Gyeonggi Dental University. Today I'm going to talk about successful impression taking in upper edentulous area. The contents are as shown. I'm going to briefly explain about the importance of edentulous treatment. I'm going to talk about the traits in doing impression taking and method, and talk about the anatomical structures and as to how impression taking is going to be done. First, I'm going to talk about the importance of impression in edentulous ridge. Complete denture should look like complete denture. The space where the denture goes in is referred to as denture space. You need to understand accurately to be able to provide a denture that is epidemiologically appropriate. Full denture needs to be functional. You need to sufficiently get information on denture space, and it needs to be in harmony with muscle tissues and surrounding tissues. In order to get information of denture space, impression taking is very important. When we treat complete denture cases, we need to take preliminary impression, make tray and take impression, take jaw relation, artificial wax, try-in is done, and final denture is made. As shown from the very first steps, impression is involved and it plays a very important role. Various clinical procedures and techniques are provided. There's a system called the Biofunctional Prosthetic System, or BPS system. Preliminary impression is taken and record base and individual tray is integrated. In other words, the impression is taken using Nesmith tray. Jaw relations is registered again. the artificial teeth is tried in and a full denture is made. As mentioned, impression takes a very important role in the early stages. In 2012, since then, complete dentures have been ensured. This is the standard that has been made then from a diagnosis and treatment plan. And up to denture delivery and adjustment, impression taking takes up 25% in terms of importance. It's quite high. Those of you interested in BPS or digital denture, there are even more clinical procedures related to impression taking. Impression taking takes a very important role in complete denture treatment. Let's take a look at the importance of impression taking after taking final impression of using various landmarks. Record base is set, wax rim is done, and artificial teeth are aligned. After looking at anatomical structures, the vertical dimension is set as shown on the right. If the impression does not reflect the retromolar pad or if it is deviated to one side, then the artificial teeth will not be properly aligned. If you look at the contour of the denture, the actual impression should be shown like the red denture, but if the impression is shorter like that shown in yellow, the artificial teeth alignment will be more lingual. It will take up tongue space and at times it can cause impairment in swallowing. If the contour is wrong, there can be food impaction, and because of lack of retention, the denture can fail. In the case of labial surface, depending on the marginal thickness of complete denture, then it can cause negative impact on aesthetic profile. When we take impression in the edentulous ridge, it may look different, but based on alveolar crest, then there can be specific vestibule in certain distance. This is average changes in coronal traces through canine, premolar, and molar regions at 1, 3, 6, 12, and 30 months after extraction of the teeth. As shown, from where a certain tooth is to a certain distance, there is vestibule on the buccal side. You need to take impression of that vestibule well, and even if continuous resorption of the alveolar ridge, the border does not continue to change, the original border is maintained, and by continuously doing relining, the denture can be maintained. In taking impression of the edentulous ridge, the appearance of the denture is important, and it also becomes an indicator on the buccal side of the artificial teeth. I'm going to talk about the traits and method of taking impression in the edentulous ridge. The definition is as shown, and impression can be divided into impression taking and impression making. Crown ridge impression taking is impression taking, and taking the impression of the lower tissue is impression making. Taking impression of the soft tissue is impression making, and it requires technique. As for edentulous patients, we need to do border molding for impression making. Impression taking, which is taking impression on fixed tissue, this can be done by anybody. Making impression of the depths and width of vestibule and taking impression again is referred to as impression making. A lot of people like digital dentistry these days, and some people try to take impression using digital technology for edentulous ridge, but that's not easy. But you can do scanning up to attached mucosa and then make individual tray and make impression of the rest of the border. That is the standard these days. There are various theories for taking impression. I'm going to gloss over them, whether how the pressure is applied. It can be defined as pressure impression technique. When maximum amount of pressure is applied on mucosa, this is an impression method to replicate the form of alveolar bone as much as possible below mucosa. The problem with this is whether the pressure that I've applied is the same as the pressure that the patient is going to apply upon mastication. If you apply too much pressure, then it can lead to impairment in blood flows. At rest, when you take impression of mucosa, this is called non-pressure impression technique. There's also a technique called minimal impression between pressure and non-pressure impression technique. To do this, you can either use tray or use impression material with good flow. This is a selective pressure impression method. This is a minimal impression technique. This is something that we do at the university, and wax is used for relief, except for posterior damming. In the lower, just leave the buccal shelf and then relief is done. This is individual tray made in this way. For instance, in the lower, excluding buccal shelf, a paraffin wax is removed, and using the same impression material, and if the same pressure is applied, then buccal shelf will be subject to more pressure. This is selective pressure impression method. Pressure amount can be adjusted, and this can be adjusted using tray or impression flow. Let's look at pressure impression and non-pressure impression. Let's look at local stress. With pressure impression method, the overall stress is distributed. Compared with the non-pressure method, with pressure impression, local stress is distributed. This is another advantage. At our university, we prefer this method. There's also open or closed mouth technique. In the case of open mouth technique, this is Voucher's technique. And closed mouth technique, it's done with a patient. The open mouth technique is surgeon oriented, and closed mouth technique is a patient also partakes in it. The difference is that in the case of open mouth technique, seal is of importance. The purpose is to distribute load-bearing stress as much as possible. In the case of open mouth technique, it centers around adhesion. The emphasis is placed on distributing load-bearing stress as much as possible. In the case of closed mouth technique, suction is important and denture border seal is of emphasis. In the case of upper denture, if you look at border seal, in open mouth technique, the inner surface of the margin, the seal is considered very important in basal seat. In the case of closed mouth technique, seal up to the exterior border is very important as well. In terms of functional movement, this is done by the patient. The patient says IUAO, tapping and swallowing. If the patient moves the tongue to move between left and right of the upper lip, then you can get all the functional movement that you need. There are different types of trays available, stock tray and individual tray. And it is used depending on different purposes. And depending on the closed type and open type, it can vary. The last is dynamic impression. It reflects the form of gingiva physiologically. It reflects the record of gingiva. It shows a certain time of period. For impression, you need either treatment denture or transition denture as shown on the left. In non-functional position, you cannot get functional impression. You need to change the denture to treatment denture and take a functional impression and come up with a definitive denture. Let's look at the anatomical structures for understanding impression. First, it can be divided into supporting and marginal structures. So let's look at the three supporting structures. First is mucous membrane. In the alveolar ridge area, if we take a closer look in the center, the submucosal layer is more developed compared with mucosa. It means there's more cushion. In the case of medium palatine suture, the mucosal layer is much less than keratinized tissue layer. So even with little force, the patient can experience pain. If you look at the head palate in the anterior side, there's a lot of adipose tissue. So it can move a lot. In the posterior side, there's a lot of gland tissue and there can be a lot of mobility. Based on this data, when we take impression, we perform relief. This is relief area based on textbooks. If you look at a literature that I've looked at, in the amount of deviation upon pressure is highly variable. It's very difficult to discern where pressure is applied more. Therefore, in our case, except for post-stem area, we do relief. Same pressure is applied, and we try to make a clinical practice more easier. As written in Vouch textbook, the incisal papilla and rugae, there can be more pressure there. But as mentioned earlier, the pressure when you take impression and the pressure when the patient chews may not be same. We don't know that. Therefore, we need to proceed with treatment easily and then respond thereafter. That is the policy we have at the university. In the case of residual ridge, in the area where occlusal force is vertically applied, it's primary stress-bearing area. This is utilized and there's a secondary stress-bearing area around it. In the case of head palate, the incisive papilla is noticeable. When we align the sixth anterior, this is the basis. Thus, papilla continues to move. With a mucosal resorption, papilla moves forward. Please take note of this. When we look at the palatal vault, it is important to determine the prognosis. In order to do so, we need to look at the 3 points. First is support. This is in terms of factors which resist the forces in vertical direction towards the bearing surface. Whether support is going to be provided. Second is retention. It is resistant to dislodgement forces and vertical forces. Third is stability. It is resistance to laterally oriented dislodgement forces. You need to look at these 3 factors and determine whether prognosis is going to be good. Can I ask you a question in the middle? Yes. Talking of head palate, a question comes to my mind. One of the most frequent complaints we hear among patients is that when using complete denture, there is crack in the middle or it cracks into 2. In order to prevent such complication, what kind of precautions should we take in taking impression? And do you have any useful tips for us? Or words of advice? That's a very sharp question. This is something that I've experienced a couple of times. When occlusal force is applied, some mucosal deviation is not evenly distributed, leading to this problem. For instance, in the case of floor of the mouth with a normal form, such problem does not occur. If the medial suture line is very prominent, or if there's prominent torus, this kind of problem can occur. And this area becomes fulcrum and a fracture occurs. In order to prevent it, you need to apply more pressure, removing except for the torus area, you press upon the surrounding tissue as much as possible, and in that state, with the mucosa deviated, you need to adjust the torus accordingly. In clinical situation, in the torus area, you add 1 paraffin wax and press it. If the mucosa appears to be pressed even more, use 2 layers. If it does not change anymore, just use paraffin wax in that area, and for the rest of the surrounding tissues, press upon it using the same force. By doing this, you'll be able to get better results. The alveolar ridge can change, therefore, you need to continuously check and do rebasing and relining. Another point is that occlusal balance is important. This can cause problems, and you need to also check the occlusal force. When you take impression on the tray, perhaps you can punch a hole so that the impression material can fall out. It's a very great idea. In our university, you don't really punch holes. If you do relief, you can either punch a hole or use paraffin wax. It's a great idea. I've overlooked that. No problem. Thank you for the wonderful lecture. I've asked a question myself. Perhaps we can look at the real chat screen to look at some questions. 찰랑찰랑, I look forward to Professor Kwon's lecture. Smile again. Hello, Professor Kwon. I'm honored to meet you at Proselytics on Friday. Coffee addicts. I have a question. There are many ways to find the VD. Which way do you prefer the most and what is the reason for it? Vertical dimension. To give you a brief answer, I use measurements of the profile. I look at the ratio between upper third, middle third, and lower third. I follow the McGill and Willis method. In other words, the length between the corner of the eye and the corner of the mouth is the same as the length of the lower third. When you look at it, feeling comfortable. That's functional, so I use this most frequently. Today we're talking about upper impression. Vertical dimension will be addressed later when we address the jaw relation between upper and lower. Do you really give? In the past, Gothic arch tracing kit used to be about $500. How much is it on dental site? This is slightly off topic and I'm unsure as to how much is the Gothic arch kit. I believe Gothic arch method is very good. I use it sometimes. Did you pay $500? No, I think I've bought it cheaper. So I'm going to check whether it is sold at dental site, and if there's price available, this will be shared. Phrygia flower. It may vary depending on patient. What is the most ideal VD? This is about VD. This will be addressed later. Good idea. What kind of form do you prefer when you request PPS area design in the upper? This will be addressed in my lecture. Phrygia flower, is there a tip in getting good impression in edentulous ridge? In the case of preliminary impression, you need to use a more tough, solid material like putty. In the case of definitive impression, the know-how is to just pray hard. If you have good preliminary impression, then you get good definitive impression. You need to do a good job from the first step. I believe this will be addressed in the later part of my lecture. We'll entertain up to this question: do you really give out coupons? There was a patient with upper full complete denture who continued to have crack in the midline. I've tried various methods including using mesh and doing rebasing. However, the same area continues to crack and it's really a pain in the ass. How can I solve this issue? Do you have such experience? I've had the exact same experience recently. I do have that experience. I've tried metal, but even with metal, it becomes bent. The fact that it fractures is that in some sense it is very good because the patient is functioning and the patient needs to have power to be able to do this. Back to the basic, you need to look at the impression and all the first steps, how you provide relief and looking at the submucosal deviation, and design needs to be reviewed once again. I'll do it again. If you are into more detailed answers, please reach out and we'll provide such answer individually. We will end the interim Q&A session now and we will entertain the rest of the questions at the end of the lecture. Dear viewers, thank you for leaving words of encouragement and questions. I look forward to your continued participation and support. Among those who have raised questions, you'll be able to try your chance out at winning Views and Music Tiger set and coffee coupons. I look forward to your keen interest. Can you please carry on with the rest of your lecture, Professor? Sure. I thought that this lecture was just between you and me, but it turns out many people are watching the program. I feel more self-aware now. So we have talked about supporting structure, and now I'm going to talk about the marginal structure. It's related to sealing of the denture labial buccal vibrating line. In the case of labial vestibule, it's related to anterior area lip support. In the case of buccal vestibule, it can be divided into buccal frenum and buccal space. Buccal frenum, the angle is more wider in the posterior area compared with the anterior area. Compared with the anterior labial frenum, buccal frenum has anteroposterior movement. You need to have a wider notch. The more important part is buccal space. If the buccal space is too thick, when opening and closing mouth, the thickness of the denture can come in the way. Therefore, it is very important to adjust the thickness. If it is lacking here, then food impaction or denture dislodgement can occur. This is the way to check a buccal frenum and labial frenum. When forming margin, if you aggressively pull it after delivery, such work may be unnecessary. The problem with it is that if you pull it excessively, you pull up to the sulcus, so the margin of the denture can become shorter. When you take impression, you need to pull appropriately, and once the denture is fully completed on the day of setting, you can adjust the frenum area to have the appropriate length and sure frenum form. Vibrating line. This is related to posterior damming, so it's very important in the upper hamilar notch, and palatine fovea is connected. It is 1 to 2 millimeters anterior. Following the fovea, it is around that, and you can refer to it. Posterior palatal seal. The resin inevitably contracts upon curing. Therefore, the vault area, there's space. In order to prevent the air going in, we need to provide certain amount of thickness to provide a negative pressure. We can do 3 ways. We can do this upon impression after making tray form. After taking impression, you can add wax and do it, or on the model, you can do beading. You can do these kind of 3 methods depending on your preference. Vibrating line. If you have the patient and hold their noses and blow, you can see the vibrating line. You draw the line around the hamilar notch and the fovea. By doing this, you get a certain area. This is referred to as vibrating area. The area that blocks it is referred to as posterior damming. This needs to be done properly in order to prevent the air going in towards the back. There's 2 types of metal base here. If you do it like right, I think that there's a problem on the lab process. If you do it like the center, then there's the advantage of damming the posterior side, but it becomes too rough. There are many pros and cons. You need to selectively choose after consulting with your patient. Someone asked me about this. So I do not accentuate line, I find the area. If you do it like this, even if I find the wrong beading line, and even if some part gets removed, there's a lot of pressure contacts, so it becomes more favorable in doing posterior damming. I think finding the area will be more favorable. Now let's look at the practical aspect of impression. How can we take a good impression of the full denture? I've joked about it, but in order to do a good impression, I've looked up on it on the textbook. Somebody wrote that you need to visualize it. If you continue to visualize it, then the image pops up into your head. In order to do this well, you need to watch and study good denture impression and imitate it. And when my mother-in-law had my wife, she visualized the top celebrities every day. And as a result, my wife turned out beautiful. And Professor Cho can verify on this. I can, yes. Professor has admitted. So we need to continue on looking at good impressions and imitating it. Then we'd be able to come up with good impression and good denture. As Professor Cho has mentioned, the first two steps are very important. We need to take every step important. The preliminary impression needs to be done well to get a good complete denture. As I look at the questions, there was a question about how tough the alginate material should be in doing impression. This is actually addressed later. About 15 to 20% of moisture is reduced. The percentage is not really meaningful. In the case of putty, if it's watery, then you cannot push the surrounding soft tissues. The percentage is not important. In the textbook, it says about 15%. So it needs to be a little bit tougher than what you're used to. Please go on. You need to make it tough and extend it as much as possible. You need to find all the anatomical landmarks, and additionally, we need to look at attached mucosa and non-attached mucosa. This becomes the border of the tray. This is an impression-making process or border molding. At our school, there's a literature that's been published a long time ago about edéntulos patient treatment. There were 59 patients and 80 edéntulos models, and surface areas were compared. The results are as shown. According to Voucher's textbook, the surface area for upper and lower is 22 square centimeter and 12 square centimeter each. Our results are 10 square centimeters more than that. This is not to say the Koreans have bigger arch. If you take impression including the marginal border, you can get the area that is needed. So you need to take impression well. If you look at the statistics, our existing impression was short and narrow. Choosing the right tray is very important to make the right impression. The tray should have 4 to 6 millimeters left after putting in the impression material. You need to have a bigger tray, and this is the old denture on top of the new tray. You can see that it is completely different with the preliminary impression. With preliminary impression, you need to take as wider impression as possible to move on more easily. It is better to use a tray dedicated for edentulous cases, or when choosing tray, you can use the existing denture on top of the tray and find the form. Because this is not a dedicated tray here, using utility wax, the denture tray may need to be modified. By assembling these different steps, then we can get better results when we take definitive impression. The important point is here. You need to choose appropriate tray, and alginate should be mixed about 15 to 20%. Number 2 is very important, as the staff members help you prepare because they think that impression needs to be wider. They give you a lot of impression material, but with excessive amount, I cannot see the margin of the tray. Even when using significant amount, the border should be exposed to find the right position. It is very important to use individual tray very well. If you look at the mucosa, that's where the non-attached mucosa is, and that becomes the tray border. Individual tray is made like this. Because everything is magnified, the foramen area is exaggerated. So you need to check foramen area or posterior palatal ceiling. You need to check once again and do adjustment and apply it clinically. Let me talk about border molding. I've talked about a closed mouth impression and open mouth impression. We need to do different actions. So first, sucking on the finger, it makes the O sound, and protruding both lips, it makes the U sound. Retrusion makes the E sound, and then swallowing. An opening and closing movement is done. Additionally, I do tapping and swallowing. If you do tapping, it feels as if pressure is continuing to be applied on the mucosa. I use this method very frequently. When you do this upon rebasing, you can get excellent results. So I hope you try. What I want to discuss is how to form the border with open mouth technique. From the posterior area to the anterior area to the labial surface. If you do left side once, you need to do the other side, the right side once. At the very last, you seal the posterior area. So I'm going to go step by step. Maxillary tuberosity and buccal vestibule. The beginners find adding modeling compound difficult. There should be no moisture. You need to soften the modeling compound and find the length and width. To get the width, you need to pull the cheek antero-inferiorly. If the size is okay, then you determine the thickness of coronal space and buccal space with opening and closing. And then the buccal frenum. You need to pull the gingiva backwards, so it's quite difficult. You put the thumb outside the mouth. If you use your forefinger and middle finger and twist, the foramen is reflected nicely, and then you take impression. If you do it too strong, as mentioned, the surrounding tissue may become thin. You need to do it appropriately. In the case of labial vestibule, you can do it too. As shown in the middle, you can have the patient suck on the finger. In this case, the orbicularis muscle will become tense and the border molding will be done, but in this case, it will become too irregular. You soften it once again and pat it top and down and go down, then the surrounding border molding will be complete. Let's look at the pterygomandibular raphe area. You need to make this frontal part of pterygomandibular raphe tense. Hence, you make the patient open and close their mouth to the maximum. Then it will be registered. We went by step. You need to connect these different 5 steps and make the transition nice and smooth. As mentioned, many people wonder what is the difference between open mouth and closed mouth technique and which the patient would prefer. This is a case presented by one of my residents at a Academy of Prosthodontics. Please take a look. This is the conventional denture. Suction denture. The sound is not really clear, but suction effect is excellent. With closed mouth technique, the benefit is double sealing effect. When you look at patient satisfaction, in terms of function, social activities, and psychological issues, there are no major differences. This is traditional impression-taking method. Do traditional technique produce better conventional complete dentures than simplified techniques? Preliminary impression is taken, and tray is made, rubber impression is done, and then teeth can be aligned using articulator, or you can just use alginate impression and use monoplane articulator. The difference between the two in a 6-month study, the patient satisfaction and expert perspective showed that there were no major differences between the two. The quality of denture is not affected by the technique that saves time and saves materials. Do not think that there is a special technique that solves everything. I think you need to be fully aware of your own technique. It's the same with the impression material. There's alternated surface, regular type rubber, and paste type rubber. There are different options available. What material is not important. What you feel most comfortable should be chosen to do successful impression. As for the upper, I try to prefer regular type, and for lower, I try to use injection type material. Let's take a brief look at the clip. Tray is meat. Do not over rely on it. Check the tray on the model. Adjustments are done. In most cases, the frenum or the border becomes too sharp. It can irritate the patient, and we need to check. We need to check that in oral cavity as well. In the case of upper, you can check with your eyes. Just leave the stop, and as you adjust the border, then there's movement left and right. First, you need to add modeling compound to make sure that the tray does not move, and find the position. As for the vertical factor, the paraffin wax maintains a vertical stop as shown in red. Now, border molding is done, modeling compound is added. In order to make the video short, I've skipped some parts. I hope you understand. Pull enter inferiorly. For thickness, it has been added to the exterior part. Now, opening and closing is done to adjust the thickness for beginners. They think that the warm water tempering is not done and they can easily get burns, so we need to emphasize that we need to do tempering. I always put hot water and cold water. Using an electronic tub would be nice, but I prefer this method. At times, my patients, elderly patients, find it too hot. The buccal frenum, you can see that it is adjusted. Labial surface is lightly adjusted. In the upper, not a lot of dentists worry, and they do a good job. I've talked about 5 different steps, but as you get more used to it, it can become 3 steps. Or if you're really deft with your hands, you can do it in 1 step. But yes, it does matter in terms of the curing of modeling compound. For posterior, in the case of ptegomandibular raphia posterior damming, this can be done at the same time with opening and closing. Patient's compliance is very important. For definitive impression, tray is prepped. In a lot of cases, people remove 1 to 2 millimeters of ideal space, so it is very difficult to reposition the tray. I had such trial and error when I was a resident, and I only adjust the frenum and I do not remove everything else. Therefore, the impression material is trapped and more pressure is applied, but no one knows what kind of consequences this will lead to. I just do it as shown. What is important here in assistance work is that it is important to prevent bubbles from forming. Impression material should be applied up to the exterior side. This person does not have high vault, but if patients have high vault, there is higher possibility of bubble forming, so you need to apply impression material here as well. Impression has been completed. Last but not least, I'm going to show you some impression technique that you might be interested in. This is soft liner functional impression and bite seating impression using exadenture, and there's flange technique. I want to briefly address them, focusing on what is important. For functional impression, you need to make the existing denture into a transition denture. After that, you need to use tissue conditioner or reliner to do impression. That is the key. In the case of bite-seeding impression, preliminary impression is taken and tray is made, border molding is done, and using articulator, artificial teeth are aligned. And once the occlusal adjustment is done, you look at the submucosal tissue and take impression of that. The benefit in that is that all error that could have occurred through lab process can be rectified. This can also be applied for patients with very bad alveolar bone condition or in patients experiencing severe pain. In the case of flange technique, I'm going to introduce it for the interns. On the wax denture, the flange area is left. The position of the artificial teeth are adjusted and tested. After getting the position, soft liner and reliner are used, and we have the patient speak or swallow and do functional movements. We have the patient do that for a couple of hours and then do curing. Then the denture form comes out. The benefit of this is that the retention becomes very good. As shown on the right, if you do biscuit test, you can see that there's no gap between surrounding tissue and it is in tight contact. Next, I'm going to talk about flabby tissue impression. This is a problem in the upper. How to take impression of the flabby tissue. The key is to utilize flabby tissue, vestibule, and medial suture line. Taking non-pressure impression is the easiest way. Second, making the border on the vestibule thick to provide support in the anterior region. Second, in order to make sure that the soft tissue does not get deformed, you need to provide space. The vault of the upper is relieved, and in that case, a lot of benefits like retention can be lost. In order to utilize retention, you need to use a softer resin to apply pressure, and posterior damming needs to be done to maintain the denture. As for occlusion, in the premolar area, you need to position it more palatally to stabilize and maintain the denture. In the posterior area, teeth alignment needs to be done well, so that the posterior stop is positioned more posteriorly. You need to utilize these 7 points in order to address many of your questions. Lastly, I'd like to introduce a literature published in Korea Association of Prosthodontics in 2021. The literature compares the 3 types of impression-taking method: the conventional method, the non-pressure method, and the digital impression method. Comparing digital impression with conventional one, there's about 1 millimeter of difference. You need to remember this 1 millimeter deviation, so when you provide clinical treatment, you need to think of how to compensate for this 1 millimeter. Also, I would like to add that you need to consider the mucosal sinking. So this is the end of my lecture. Thank you for listening. Professor Kwon, thank you for the wonderful lecture. So we will address Q&A session in a little while. Professor Kwon, we have many questions that have been submitted. I wonder whether we will be able to answer all of them, so we will try to go through them quickly. In upper edentulous cases, at times, the frenulum can be an issue. Should we surgically remove everything or strategically leave some and provide full denture? In complete denture, frenulum does not hold significance. The muscles that cross the denture border does not hold significance. However, if you remove it, our face can shift when we run. You cannot remove the frenulum. The muscles that come vertically to the denture border is not really good. It's not helpful for denture maintenance. If there's lack of space, can we remove it? Yes, I do. What about you? I agree too. Winter, hello. If there is a lot of resorption in the upper alveolar bone and if it is difficult to determine the vestibule width, what can I do? I've talked about Professor Watt's method. From the lingual point of where the teeth used to be towards the vestibule, there's about 15 millimeters of distance in average. That's the average figure. You may want to use that figure. Rather than trying to find what you cannot see, you can utilize what the average figure is. This can be a method. Seungyu, do you need to make a notch in order to do posterior dam sealing, which is the posterior border? By notch, I think you can do butterfly. You can make a notch. As mentioned, when you apply a pressure upon impression, that is not needed. Even if you add a wax on the model, it's not needed. However, if you miss everything, if you do conventional impression, a beading line or a notch should be provided. This is for posterior damming. I think this is the question. In order for denture to be maintained, sealing is important. In the upper, there are frequently failure in seal in the most posterior area, so you need to do a good job. Light. In the case of upper edentulous case, upon impression, where it requires a functional pressure impression, and could you explain the tips? This has already been addressed in the professor's lectures. Because there are many questions, we will skip it. Wonderful. In order to fabricate individual tray for completed denture, when I use CDG edentulous tray to take impression in the upper and lower, at times the edentulous molar area or posterior area does not come out properly. Is there a tip to do a good job? In the case if the impression is not okay, rather than removing the existing alginate, can I add a new alginate and mix it and take impression again? CDG is from Professor Choi Dae-gyun. It's an excellent question. To do a good job, you can add alginate on your fingers ahead in the maxillary tuberosity area. You can do it ahead. This can be a good idea. Check if the impression material is too watery. If partial bits are lacking, there are alginate adhesives available in the market, and use that to do wash impression. Then you get a good result. This is not the textbook method. I do this frequently. The proper method is to remove it and do it over, but at times by doing the method that Professor Kwon, you get a better result. I won't comment on this. Yes. Could you summarize the anatomical landmarks that should be included in the impression? There are so many. To put it bluntly, you need to look at the textbooks. It's all there. JM2875, selective pressure impression if there is severe bone resorption, and I believe this question is related to lower, and the lower will be addressed when Professor Kim Jong-un is here with us in the next lecture. Larigi, what are the step-by-step points for successful complete denture fabrication? The scope is too broad. I believe all steps are important. As for irreversible hydrocolloid impression material, why do you use less water in edentulous cases? It's the same with rubber in terms of adjusting flow. It's not because it's alginate. Be it rubber or alginate, you need to adjust the flow. ID beginner, when border molding the final impression, you can either use compound wax or use heavy body to cuff back and repeat, which is more accurate and convenient. I provided a lecture on this previously. You can use polyether impression, yes. Do whatever is more comfortable for you. For beginners, in order to practice, you need to practice using modeling compound sufficiently and then move on to rubber. But I recommend doing practice using model compound. You need to focus on basics first and then move on to whatever is your preference. 보라. In the case of patient with a severe gag reflex, how can I take a good impression in the posterior area? Gag reflex. I've heard about having the patient lift one leg. In the case of patients with severe gag reflex, I'm unsure. It's a difficult problem. There can be patients with severe gag reflex once in a blue moon, and I ended up treating the patient with implants. In the case of patient with severe gag reflex, unless a systemic anesthesia is performed, it's going to be difficult to treat. To do it simply, if you have the patient raise one leg, then the gag reflex will reduce. Because the patient puts strength on the stomach, then it will be better. If the patient feels tired about raising one leg, then have the patient raise the other one. There's such method. If the patient can withstand by doing that, that's good. If the patient cannot withstand that despite of it, then implant treatment can be provided. 콩보리, impression taking is most important. Do you remove the denture in use for a day and do impression? Yes, according to textbook. Follow the textbook. Are there any precautions in making individual tray? Where do I find the rind? As mentioned earlier, you need to think of the attached mucosa and mobile attachment. You need to find the border in between. In order to make it, you need to take impression of the mobile mucosa accurately to find the tray line. You need to look closely. High end. You said that doing impression on the mucosa requires non-pressure impression method. According to Page, impression should be taken according to Pascal's principle. What is this principle? I think you're talking about mucostatic impression. Think about syringe. If the bottle is completely sealed and if it is filled with water, the syringe never goes down. However, because there are cheeks right next to it, our mucosa is not like that. At first, the denture and mucosa fits, but with a little movement, mucosa changes and it cannot return to its original state. In other words, the principle does not fit the clinical reality. Uza, if the patient has been edentulous for a long period of time and has severe bone loss, and if the lower is protruded like class 3, upon occlusion, you do not force the anterior region and just use the premolar region. Can you share a case and a video on this topic? Class 3, artificial teeth. I think this person is talking about occlusion. I believe this will be addressed by a next lecturer. When talking about aligning artificial teeth, please raise your question once again later. All then, what is the one most important thing in taking impression in the upper? Taking impression in the upper, you need to take a good preliminary impression. Take a good preliminary impression. One of the tips was to use the alginate with less moisture. If you have the funds, use putty. If you're really into it, use putty. Shin8234 has asked the same question as to how much of a ratio you should do with alginate. You've talked about the 15 to 20%. Reduce moisture, that was the key. Squid and peanuts. What are the factors that affect the satisfaction of the patient on new denture for complete denture patients? Will impression taking take up the lion's share? I do not believe so. I've looked at a literature from King's College. In terms of patient satisfaction, 4 factors were reviewed. Form of the alveolar ridge in the lower, and the retention of the denture with good impression, adaptability, jaw relation. 4 factors were compared. The results show that jaw relations affected patient satisfaction most of all. The accuracy of the lower impression may affect the jaw relation, but it does not directly affect the patient satisfaction. Even if you do a rough job in taking impression, if the jaw relation is okay, the patient satisfaction will go up. Even if you take a great impression, and if jaw relation is poor, then the patient will not be able to use the prosthesis. In that sense, jaw relations is more important. Today's topic is impression, and I want to say impression is most important, but if you look at the literature results, impression may be important, but jaw relation is very important as well. I'm curious about the suction denture. It's going to take a long time to explain. I believe the next lecturer is going to talk about suction denture. Professor Lee Hoon-jae is going to talk about it. He's going to talk about BPS and address the topic light. Should the thickness of the marginal border of the denture differ depending on surrounding tissues such as lips and muscles? Is there a special way to set the thickness of the appropriate denture border? I'm thinking this person is talking about the flange thickness. When you do border molding, don't take it out of the oral cavity. Just leave it in the oral cavity and take a look. Take a look, and if it's sticking out, then you apply more force. If it's lacking, you add more. Depending on your handiwork, it may become more thick or thin. You may be able to get better results if you consult with a patient, the overall profile and such. With the tray, if you take a look, that becomes the appearance. Depending on the level of resorption the patient has, the thickness of the tray will differ. BC Den. When you do posterior palatal seal in direct method, resin will be applied in the form of butterfly, but it'll lead to failure of posterior seal. Is there any tip to solve this problem? At times, I add direct resin. You do not need to use a butterfly form. You just do it, and then you have the patient bite. Once it sets, you have the patient open mouth as much as possible and apply pressure in that side. If the patient bites it in a different way, then there can be wind going into the other side. Therefore, in my case, in the case of trying to achieve posterior palatal seal, be it with pressure or not, I apply notch. I do beading from the start. If the patient complains of discomfort, we can adjust it. I think it is better to do it and then respond to it laterwards. Professor, rather than modeling compound, there is border molding impression material from GC. Have you used it? What is your feedback on it? Yes, I've used it and I've given a lecture on it. It's very easy and it reduces time. The denture, it doesn't matter. Modeling compound form needs to be understood. And then if you use it, it will be very convenient and it will be less time consuming. It's been mentioned in the literature, but techniques to reduce time and material, it could end up in good quality prosthesis. Do you really give? Upon impression taking, do you use rubber adhesive on tray or alginate adhesive? Yes. The same person has raised many questions. I've realized that there was a big difference in mixing alginate with your hands and using an automatic mixer. As a result, I believe we should use the automatic mixer when we take a basic impression. Do you use automated mixer? I don't mix myself. I ask others to do it. Using automated mixer can provide a more even material compared when doing with our hands. And moisture can be adjusted. KS, what about doing border molding using impression material rather than wax? This has been addressed before. It takes a long time to handle wax, but for some time you should follow what is written in the text, and once you get used to it, you can move on. This is a question received through YouTube. When we take impression with a lot of impression material, patients with a severe gagging reflex have a lot of difficulty. That's why the amount of impression material is reduced. Is there a way to resolve gagging reflex? It looks like a similar question. Rather than using significant amount, it's better to use less because it can go down the patient's throat. Upon closed mouth impression technique, how do you fixate the tray? There are many questions still. Can I use light body impression material upon taking impression on crown bridge? If you can adjust the flow, whatever is fine. I think this is the final question. KS, the most posterior border of upper denture can differ depending on the shape of the arch. This was written on the book. Can you briefly explain about this? Posterior border changing depending on arch shape. I think this is about whether it's before, on, or after phobia, considering the vault. The patient would be considered more favorable if the anteroposterior distance is longer. Understood? There were many questions. Thank you for answering the questions in a very clear manner. I would like to express my gratitude. Those of you who have participated on the chat, I would like to express my deepest gratitude. Now we will select the best question among the questions raised in Prosthetics on Friday. Those of you chosen as the best question will be sent the Buse Music Tiger Dental Scent, Professor Kwon. Who do you want to choose? I would like to choose someone who continues to raise questions. I would like to choose, do you really give prizes? This person has raised many questions, so in light of expressing our gratitude, we would like to choose this person. Do you really give? Congratulations once again for being selected as the best question. You will be contacted separately. Those of you who have won the coffee coupon event, the coupons will be sent on Monday via text. Don't feel too let down for not winning at the event because the real chat event on Prosthetics on Friday continues on. I look forward to your keen interest. Professor, do you have words of advice to fellow dentists? Thank you for studying with us up until late. I believe Korean dentists are very finicky. I believe such trait will eventually lead you to finding your own special something. I hope you find that soon and provide great treatment. I look forward to such day along with you. Thank you for watching. Despite your busy schedule, thank you for coming on the program. Viewers of Prosthetics on Friday, did you enjoy the lecture with Professor Kwon Gung-ruk? We were able to understand various tips on taking impression on complete denture. The questions that were not addressed today will be answered via reply. The topic for next lecture is as follows. For successful complete denture impression taking, the focus is going to be on the lower. Professor Kim Jong-un of Yonsei University is going to provide the lecture. Thank you for being with us until late. Good work. Thank you.